There are more than 1 million ASHA workers in the country. That's almost double the population of Maldives. There are more ASHA workers in India than the total number of people in Bhutan. And this mighty army of foot soldiers is stationed on the front lines of India's healthcare infrastructure. These women are akin to the first responders for medical policy implementation. They link urban, rural, remote, and the most destitute nooks and crannies of the country to healthcare facilities and provide information on nutrition, sanitation, and healthy living. The World Health Organization's prestigious recognition for their work during the pandemic, in the form of the Global Health Leaders Award, is gratifying and wholesome. Prime Minister Modi's congratulatory tweet also does one proud. The national and global attention seems ripe. But what is not gratifying, wholesome, and does not induce pride is the long struggle of these valiant women for statutory minimum wage. Launched in 2005 under the National Health Mission, the Accredited Social Health Activist program was inspired by Chhattisgarh's Mitanan initiative, a community volunteer program designed to make public health systems more responsive and accountable. The goal for ASHA was to create a cadre of local skilled women who would act as an interface between the community and the public health system. And they did. The ASHA workers are the first point of contact at the grassroots level, delegated to work with the concerned authorities to develop a comprehensive village health plan, ensure immunization for children against vaccine-preventable diseases, counsel women on birth preparedness, escort pregnant women and children requiring treatment with prenatal and postnatal care, provide curative care for ailments like diarrhea and fever, maintain records of births and deaths in the village, and any unusual health problems or disease outbreaks in the community, depending on the state, provide palliative care, screening for non-communicable diseases, childhood disability, mental health, geriatric care, along with door-to-door surveys for government schemes and other public health measures. For such an exhaustive to-do list of crucial tasks, this important pillar of medical infrastructure falls short of getting its dues, especially in monetary terms. ASHA workers are not government employees. They are honorary volunteers. As such, the government has no legal obligation to pay them a minimum wage. ASHA women receive honorariums which run as low as 2,000 rupees per month. Then there is performance-based compensation through incentives by completing a list of over 60 tasks. For example, distributing sanitary napkins to adolescent girls will fetch 1 rupee per pack of 6 napkins. Reporting the death of a woman between 15 to 49 years within 24 hours of occurrence to a primary health center medical officer will amount to 200 rupees. Ensuring full immunization for a child under 1 year, 100 rupees. Preparing blood slides or testing for malaria through rapid diagnostic tests, 15 rupees per slide or test. There is no uniform pan-India remuneration structure. The amount of these incentives and the honorariums differ from state to state. In most states, except Andhra Pradesh, Kerala, Karnataka, Haryana, West Bengal, and Sikkim, they do not get a fixed monthly payment. ASHA workers have been seeking statutory minimum wage, regularization of tenure, insurance, travel allowance, and government benefits at some level or the other ever since the conception of the cadre in 2005. Teaming up with trade unions, these frontline workers have been fighting against lax and apathetic behavior towards their complaints.
Fact is, they do not have any fixed remuneration, there is no fixed salary. Whatever they are given is almost like piece rate job. We are having these ASHA unions in 15 states of the country, and everywhere we have demanded they should be identified as government employees, at least as D group government employees. They are doing no less work than the D group employees. So they must be declared as D group employees. They must be given all the perks what is received by the government employees. If you don't want to declare them to be government employees, at least let them be treated as workers. And minimum wages of 24,000, what is decided by the Indian Labour Conference, 24,000 per month should be given.
The struggle continued even through their toughest stint at work, the COVID pandemic.
who was monitoring all of these hordes of migrant workers coming in? It was the ASHA workers. They were looking for symptoms. They were doing all these syndromic surveys. They were isolating patients with symptoms of COVID, taking them, then informing the healthcare department, and after which the team of doctors come to the village. So the actual contact of, the precarity of it, the first point of contact had been the ASHA worker during the pandemic.
Behan Box, a platform for in-depth investigative journalism on gender issues, researched across 10 states on the role of female frontline healthcare workers during the pandemic. Their findings aren't uplifting. ASHA workers faced an increased burden of work, from 6 to 8 hours a day to almost 12 to 15 hours, while being on call for almost 24 hours. The wages took a hit. 86% of ASHA workers reported a drop in their incomes and reported an average delay of 1 to 6 months in receiving their remuneration. The late and low payments exacerbated debt situations for many. There were instances of discrimination and violence against them, both from within the community and from other healthcare entities and government officials, including the police.
A lot of men, especially in very patriarchal states, they found it very difficult to take orders from women workers. In the early stages, if you remember, they were asked to put quarantine messages on homes that had COVID positive patients. This was what ASHA workers were supposed to do. And when they started doing that, there were a lot of physical attacks on them. So, something like this becomes a chance to perpetuate a kind of violence that already exists in the society in the way, frontline workers are treated.
Unnervingly, there was also inadequate distribution of masks, gloves, PPE kits, and other protective equipment. Along with the Herculean mental and physical pressure, some ASHA workers also saw their colleagues succumb to COVID.
I remember one ASHA worker I interviewed in Assam told us how the health department gave, because they had gone to monitor and isolate a COVID positive patient. So the team of doctors had come and they were wearing hazmat suits, and so they gave one to the ASHA worker, and she put it up in her WhatsApp group and said, "Hey, here's this. We've been given. I'm wearing this hazmat suit." And one of the healthcare department officials had told her that, why are you wasting one suit over yourself? This would go to actual healthcare staff. So that is the kind of, recklessness, that's the kind of apathy we saw towards healthcare workers who were actually day in and day out on the field, working close to sometimes 24 hours.
Some researchers and health experts have blamed this unmindful treatment of ASHA workers on the devaluation of their work as emotional and feminized care work. It reflects a hierarchy in the medical infrastructure and gendered damage to the system.
Each ASHA worker has to take care of about 1,000 individuals. And despite this large burden of work, they are not given minimum wage, which becomes a problem because the nature of their work does not leave enough time for them to seek alternative employment opportunities. We are demotivating our public health system. The way it is structured is demotivating an important section of the healthcare community in our country, particularly such a community who has reaches into the most remotest corners of our country. ASHA workers have the capacity to navigate complex social and economic terrains. They have an intimate understanding of the health needs and health requirements of their communities, and discounting such work would only adversely impact our medical infrastructure that relies on door-to-door campaigns for effectively providing public health services.
ASHA means hope, and that's what these unsung heroes and their advocates are holding on to.